Hi, I'm going to talk a little bit about our slideshow, Leading, Managing, and Delegating. It's a PowerPoint available for week 10. The objectives are we're going to describe the process and strategies utilized in nursing practice by the nurse to make competent decisions to improve patient care, define the nurse's role in coordination, defining managing skills, and describing the behaviors of professional competent nurse leaders. So what skills does a leader have? Well, leaders have a commitment to excellence. They have great problem-solving skills. They have a commitment to and passion for one's work. They are trustworthy and they have integrity, meaning they're true to themselves and they're true to the mission of the organization. They're respectful of themselves and of others. You're accessible to them and they are accessible to you. They have empathy and they're caring, and their responsibility to enhance personal growth of all the staff. Does that mean that they're an expert? It doesn't, not necessarily. They may have a lot of experience and have expertise to share, but sometimes leaders know nothing. In building a motorcycle, the CEO of Harley Davidson knows nothing of how to true a wheel. He knows nothing about how to tune the fuel injection system. So they may not be experts on the technical aspects, but they may indeed be the best leaders, and they may be an expert at leading people. Case in point, a midnight supervisor at a hospital, they often or overlap over every area of the hospital, and they may not be expert in OB. They may not be expert in surgery, but they know how to find the information that they need, and they know where to get the people who do know things. We want to, as building our leadership, we want to achieve self-knowledge. We want to identify our strengths, evaluate how we accomplish our work, clarify our values, make sure that they're consistent with the mission of the institution that we're working for. Sometimes it's really disappointing to realize that the values that you have are not consistent with the place that you're working. So determine where you belong. For example, the person that wants to work with an exotic bicycle company, but has the value that he thinks everyone should have a bicycle, those two sets of values are inconsistent. Not everyone can afford, nor can everyone be given an expensive bike. Determine where you belong and what you can contribute, and assume a responsibility for relationships. There's always talk about different leadership styles, and any class you'll ever take in leadership, they'll talk about different types of leaders. Autocratic is a person that says, it's my way and this is what we're going to do. An autocratic leader can be a dictator, or they can be someone that's firm about the direction that they do. A democratic leader is one that tries to intake everyone's input, helps to build teamwork, build collaboration, and they attempt to get everyone working on the same page. Sometimes they rely on votings, they rely on consensus. A laissez-faire manager is one who takes a hands-off approach to some aspects. He may have some aspects that he's very, very involved in it. Raising my children, there were many things that if I really didn't have an input about it, that I wasn't going to give them an opinion on, what should I wear to school today? What color should I wear? I help them, I give them suggestions, but it was pretty hands-off. They could wear what they wanted to wear. I would try to lead them making good decisions. But they all knew that I had certain lines that they wouldn't cross that were things that were my value. Servant leadership. At my schoolwork at Gonzaga University, our leadership course that we needed to take for our master's in education really focused on servant leadership. Peter Plummer is a great author if you ever want to learn more about that. A servant leadership who is one who seeks to serve the company itself seeks to serve the employees themselves so that they can get the job done. But in fact, they have the expertise, they have the ability, they are truly a leader. They can remove the aspects that aren't consistent with the mission, but they are there to serve. It's a servant leadership in nursing would be one that makes sure that people has the ability to do their job. They have the expertise, that they have sufficient personnel, that they have the materials, that they have the medicines. Best example I can give you of a servant leadership would be the Sherpas that help people climb Mount Everest. They are there to serve the climbers, but they're the ones that are actually leading the expedition up the mountain. They're the ones that are going to keep those people safe and keep them going. They're the ones that are able to read the climate and know if there's a storm or a snowstorm or a windstorm coming in. Very important. One famous Sherpa was Tenzing Norgay, who was a Nepalese servant who led Hillary up to summit Mount Everest the first time. Without him, Hillary would have never made it. And it's interesting, many people need supplemental oxygen. There are several Sherpas out there that don't even need oxygen to summit Mount Everest. Quantum leadership. I really have never got a full grasp of quantum leadership. It's more of a new age type approach, that there's a certain flow to the work that you do, that there is a certain ideology that permeates the organization, and that quantum leadership will pull the organization through that. I found it difficult to understand, and probably even more difficult to implement. Transactional leadership is those who simply lead during their transactions that they have with employees, with suppliers, for example, with physicians in a hospital, with the nurses. And once that transaction is completed, then that relationship ends, or that current relationship ends. And transformational, we'll talk more about that in a bit. So, management structures, they're centralized. Most hospitals do function, with a central administration, a central nursing administration. Their senior managers generally make decisions with little input from the group. Then there's decentralized, where each individual area has sole determination of their own fate and how they're going to accomplish the work. An example that I could give you that in a hospital is many areas in a hospital are, they work from a centralized staffing structure, meaning if one area is low, people can be pulled from, say, CCU to work in 5 Main, which is a telemetry floor, but may not have the exact amount of expertise, but it's a decentralized. Now, however, if CCU were responsible for staffing themselves, they would not be pulled to other units, but in times of crisis, there wouldn't be anybody to pull in. They would be responsible for staffing themselves. Okay, decisions are made by those who are most knowledgeable about the issues being decided, and nurses are thus intimately involved in decision providing care. So that's a decentralized nursing structure. Leadership, the leadership roles, it assigns, delegates, and supervises, puts the right people in the right work, delegates who should do the work, and supervises that the work is done right. We've talked about leadership styles. We haven't talked yet about management of care, but that's where everyone has the ability to manage they're more or less like a concierge for the patient, making sure that they get the help and the assistance that they need, through their entire hospitalization and for their discharge. One of the leadership roles is prioritization, setting the priorities for the organization and on a more global scale, not necessarily on the day or during a shift schedule, time frame. Time management, making sure that people are spending sufficient time on the things that they need to do, making sure that they have the staff to be able to do it. And the leader is also responsible for keeping up with the trends in healthcare, seeing if there's something more, better, different they could be done in the area that they're charged with, and to make sure that staff is practicing according to evidence-based practice. Care coordination. The registered nurse coordinates admissions, transfers, and discharges. That's what ADT, you'll hear that abbreviation. Facilitates the continuity of care provided by the health care team, initiates, revises, and evaluates the patient's plan of care, and reports the patient status to other providers and facilitates referrals and the use of community resources. So that's that role of that individual nurse. But that also is the role of the manager of that institution to make sure that those people are able to do that work. Time efficiency. Leaders need to do this. Individual employees need to do this. Establish goals and priority for each day. Anytime when I would have a leadership type of position, which was about 3/4 of my nursing career, I always had a to-do list for a day. There was always work that would come up during the day that you needed to attend to, but anytime you had a break or you had an opportunity, you would float back to work on completing that to-do list. So making sure that the goals are consistent with the ability to meet the needs of the patient. Establish a timeline for getting care done for a project to improve care, and evaluate your success and failure. Be able to reflect on how you used your time, better or worse than how you could use it, do it better, and utilize these results to direct your next day's care priorities and timeline. Delegation, perhaps, and it is probably one of the most difficult roles that you'll have to take care of as you're working, is making sure that that the right people are doing the right job at the right time with the right knowledge. And we tend to be a little codependent, look the term up, in our practice, meaning sometimes we're unable to relinquish control. We tend to be controlling type people, and we don't want to relinquish control if we don't think so, but we want people to do the job as we would do it. So oftentimes we have trouble delegating because we want to make sure that it's done right, and that doesn't always have to mean that you do it yourself. ANA principles for delegating. The nursing profession determines the scope of the nursing practice. We've talked about that. The nursing profession defines and supervises unit assistants involved in direct care. The nurse is responsible and accountable for nursing practice. The RN supervises any assistant providing direct patient care. The purpose of the unit assistant is to help in the supportive role of the RN. Factors to consider when you're delegating: qualifications and capabilities of the unit assistant, stability of the patient condition, how sick they are, complexity of the activity to be delegated, how much knowledge is required, how much experience is required, the potential for harm, the predictability of the outcome, which, how predictable is what you expect to happen from this particular intervention, and that comes with experience. That knowledge comes with experience. The overall context of other patient needs, seeing how it fits into the big scope of that patient care. Other considerations: making the patient's condition, complexity, potential for harm, degree of problem solving and innovation necessary, level of interaction required with the patient. Backing up a little bit, to the degree of problem solving and innovation necessary. RNs, as opposed to a unit assistant, have the ability to vary from the script, meaning if they don't always have to follow the exact order of care, if they think that there's a better thing to do, a better way to do it, or it wouldn't be appropriate in this situation. That's not often the decision of the unit assistant that the unit assistant has when they're making their defining their task, completing the task. Level of interaction required with the patient, whether it can be strictly a social, encouraging communication with the patient, or whether it needs to be a truly therapeutic, directed communication. And we need to know the capabilities of the individual licensed practice nurse and the unit assistant, and the availability to have nursing staff to accomplish the workload. The rights of delegation, and you'll hear these: the right task, making sure that it falls within each person's job description. The right circumstance, meaning the patient's healthy enough, there's limited decision that needs to be made, the outcome is predictable, and there's little need to vary from the script. And the right person, which fits within their scope of practice. I should add that many times we have scope of practice, and the state allows people to do certain things, but then there's institutions may vary from that. For example, in Ohio, it is perfectly all right if you're administering blood to have one of the people double checking that blood to be an LPN. However, any institution that I've ever worked in the last 20 years always required that second person checking it was an RN, and you couldn't use an LPN. And right directions and communication. Each delegated situation should be specific to the patient, the licensed nurse, and the delegatee. They're supposed to communicate the need of what needs to be done, depending upon how much direction the person needs is how much information that you give them. If I'm asking a second-year student to do something as opposed to a first-year student, I'm expecting I'm going to need to give them less direction, and that they're going to be able to complete the task more likely individually. So you don't want to overdo it. If I'm a charge nurse and I'm asking a staff nurse to do something for me, I certainly don't want to have to give them, or need, or desire to give them, step-by-step directions. I'm expecting that they know how to do it. And the right supervision to make sure that the person, it's being done right, and then evaluating the outcome. And that, once again, that's really, really hard to get it to that point where you're able to evaluate the outcome, because we want to do it ourselves. This is one of the common refrains that you'll hear from a nurse, is that if I'm responsible for someone else doing it, then I'd rather do it myself. So you need to make sure that you have competent people working for you, and that you're giving it to competent people, and if things happen, that that person's communicative. So, okay. Accountability, sometimes that is really focused on being retrospective, which means that there's a critical thinking and looking back to make sure that the way things were done was appropriate and the right answer. And so if I screwed it up, I need to own it. If I did it right, I can own that too. So RNs, just demonstrate that accountability by answering for themselves and the people that work for them. So, and we make sure that that person is capable of being accountable by, having them adhere to the standards of care by the American Nurse Association, and by making sure that they pass their boards. And by virtue of our professional licensure, we have the authority to transfer selected nursing activity to a situation of a competent individual. For that reason, if you would see a test question that asks, can a senior nurse's aide delegate to another nurse's aide? No, they don't have that authority to do it. They can ask for help, but they don't have that authority to be able to delegate to another person. So, okay, I'll let you review this yourself. Certain overlaps between, how we protect the public, how we train and educate, how we communicate, and the responsibilities of the individual care person. Conflict resolution. Conflict resolution strategies mean avoiding, taking the long road home, collaborating, competing, compromising, cooperating, accommodating, or smoothing. So smoothing and avoiding are very close together, where it's, avoiding, you just can ignore the problem. Smoothing, you tend to minimize the problem, or just try to minimize the effect on people. Collaborating and compromising are shades of the same thing. As long as along with cooperating. Collaborating means you work together to a solution. Compromising means you give and take. You get part of what you want to give up, and give up part of what you want so that the other person has. And cooperating means that they work together. So don't worry about, you'll never see testing on trying to differentiate between cooperating and collaborating. It's not different enough. Change. You'll see readings on Lewin's theory of change. Unfreezing means that we break the mold, that we break the way, this is the way we've always done it, and we create the need and the recognition that a change is needed. Moving, and change is initiated after a careful process of planning. And refreezing, making that practice and standardized practice. Consideration for plans change. What is amenable to change? What can we change? How does the group function as a unit? Is the group ready for change, and at what rate? Are changes major or minor? I know managers and administrators within hospitals right now are, although they're forced into rapid change due to our COVID condition, they also are minimizing the amount of other changes that staff has, because the stress is and the workload is so high right now. Okay. So this fitting along with Lewin's, the plan change process, we recognize, we unfreeze, we identify the problem to be solved through change. Once again, we're determine and analyze alternative solutions. We're moving towards that. Select a course of action from possible alternatives. Plan the change, implement selected course of action, and evaluate the effects of change and stabilize the change. So this dovetails off of our decision-making exercise that you guys had. I'm one, I do make a list of pros and cons when I'm having to make a big decision or to make a big change. And I'll assign arrows of force, whether it's a big drawback, whether it's a big positive, or also the impelling forces. I really want to add sometimes change is initiated from within, within the organization, within the profession, and sometimes it's motivated, or it's a pull from without, from outside, from society as a whole, other professions, accrediting or standardizing agencies, create a need for change. An example within nursing is, although we still have multiple entry levels into nursing practice, eligibility to take the NCLEX, there is a pull from outside of society. It's probably 10 to 11 years old, where the Institute of Medicine, now known as the National Academy of Medicine, came in conjunction with the Robert Wood Johnson Foundation, came up with a study and suggested strongly that by this point in time, 80% of the nursing workforce should be BSN prepared. So, and that's been the motivating factor for the growth in the RN to BSN programs, like the OU program. Once again, I really want to emphasize too, after just saying that I really think you guys are some of the smarter ones that are actually getting your ADN first and then allowing other people to pay for your BSN. Within 2 years, you can, get out into practice and be making the same amount of money as a BSN. Then it's up to you to compete for the future opportunities by completing your BSN. So, within your career, you probably are not going to be able to escape getting a BSN. Let's see, your age, and let's see, I have a daughter, 29, and she's an LPN, and I've strongly suggested to her that she's not going to be able to get through her career as an LPN, or without being a BSN, and possibly even that she may need to have a master's to do the things that she wants to do in the future. She's very motivated. She loves independence, so she may be required to get a master's degree in her future. Reasons that people resist change: it's a threat to herself. If we change something, if we start buying cars and using rubber tires, is the blacksmith going to have a job? Who resisted automobiles? The blacksmith. Lack of understanding of why or what's to be changed or what the outcome should be. Limited tolerance, and people at different points of their life and their career have different tolerance for change. That relatively new practitioner may be open to change, but there's a point where they want a certain stability and don't want constant change. People that were well mature in their practice, like I was before I left direct care full-time, although I still practice it, sometimes it just got so hard to unlearn things. I always laugh and joke and tell people that I have drug dosages floating around in my brain from old standards for advanced cardiac life support, drugs that haven't been given in 20 years now. So, disagreements about the benefits of change. When we've just experienced that firsthand with our elections, and fear of increased responsibility that comes with it might be perceived to happen with change. Okay, how do we overcome resistance? Explain the proposed change to all affected. List the pros and cons. Relate the change to the person's existing beliefs and values. remembering, well, jumping back to our Bloom's taxonomy, it's the hardest place to affect change or to teach is within the affective disorder, to change people's values and beliefs. We want to provide opportunities for open communication and feedback, indicate how the change will be evaluated, will be consistent, introduce the change gradually. That's also done for another good point of view. Used to write some computer programs, and there was an idea of doing stub testing, meaning you do complete one section, test it out, and then move on to the next section, complete it, test it out, and so on and so forth. That way you're able to identify exactly where the problem lies, or decrease the amount of variables. Within Mercy Medical Center, a lot of times certain nursing units would begin new practices to implement, and they would look at how that happened on those units, and then they could make some adjustments and then institute the whole change throughout the entire nursing department. That's what happened with when we went to electronic medical administration. So it was introduced on a couple units first and then gradually spread to everyone. And provide incentives for commitment to change, and that sometimes it can be nothing more than that pat on the back and that attaboy, or it could be financial rewards. So factors that increase the power base of nursing, making sure that we have the right time, the size of our nurse, the right timing, that we're needed now. There is a shortage, which tends to be cyclical. There's shortages at times. Then there's when people tend to go into the profession that may create an overabundance, and then people realize, oh, I'm not going to be able to get a job, so they stop going to pursuing that education. And there's other factors, of course, at work. I mean, the workforce that's my age is retiring. The new workforce, there's not as many of Gen Z people coming in as there are boomers and soon to be Gen Xers that are going to be retiring. Okay. Knowledge is power. Nursing has a unique perspective, and because nursing has a unique perspective from anybody else, it also sometimes makes it very difficult for us to explain exactly what we do. So, or people don't fully appreciate what we do. Well, I'm caring. Well, what does caring mean? I'm, Joe Bolo up the street, Joe Bag of Donuts, he's caring too, but, our caring is motivated and pushed by evidence-based practice. So, role of nurse manager is to plan, to organize, to staff, to direct, and controlling. Controlling it's not this autocratic leader. Controlling is a term that means financial control. So they're responsible for the budget. The CFO of an institution used to be known as the hospital controller, the chief financial officer. When we look at advanced practice, there's multiple areas of advanced practice. You've heard of nurse practitioners, there's nurse leaders, and then there's also nurse educators. And those are the clinical nurse leader works collaboratively with other healthcare teams within a facility to facilitate, coordinate, and oversee patient care. The clinical nurse leader should be able to clearly communicate with other health professionals, integrate evidence-based practice, and evaluate patient risks and outcomes. The person-centered focus of clinical nurse leadership includes functioning as a patient advocate, educator, and provide patient care in complex situations. Okay, developing leadership responsibilities, mentorship, preceptorship. I know one thing that we commonly do. I also teach critical care, which is your last course, and there's a big aspect of um, leadership and management in that management of patient care. And when I would take students into the hospitals, in that last course, I oftentimes would try and find a mix of people, of nurse and staff, a nurse and student that would work well together. It was really nice when I was going to the unit that I worked on, and try and match them up throughout the semester so that they gain some perspective, kind of a pseudo preceptorship. There's many contemporary leadership theories. There's transformational leaders, and transformational leaders tend to focus on people, challenging norms, and continuing to fundamentally change and lead people towards. There's the four aspects of it that you had to do for this week's discussion board. The idealized influence, the individualized consideration, intellectual stimulation, and inspirational motivation. Shared leadership and shared governance. Their shared leadership is it's more of a matrix type of structure where you have different roles within different areas of the hospital. For example, when I worked at Massillon Community Hospital, we had a cardiac matrix. We had leadership down that track. Then we had an orthopedic track, and then we had just a general med surge. So there were different roles for the leaders within that. So it was shared leadership, meaning it was decentralized. So a certain amount of that leadership was assigned to staff and middle management within those units. And shared governance is very similar. That's what most institutions now are instituting some form of that. For example, Mercy has a Nutrition Leadership Council, which consists of many, many staff nurses, and they're able to gather the evidence, formulate a plan, and help to have those practices change. Of course, there needs to be a blessing off by senior nursing leadership. So we talked about servant leaders before. I talked about Tenzing Norgay, the Sherpa. So he had the vision to get people to the top of the mountain, and he wanted to listen and learn what their priorities were. I want to get to the top of that mountain no matter what, meaning I'm willing to take a bigger risk than other people may, and they're willing to sacrifice their own notoriety and to invest in others' greatness, so to make the other people great. How many people have heard of Tenzing Norgay? But many people that are into mountain climbing do know who Edmund Hillary was. He was the first person to summit Mount Everest. You give away your power, you're in the background, and you're building your community by strategic relationships. Okay, I'll let you review this. 7 Habits of Highly Effective People. I'll let you review those things on your own. Magnet recognition program. Institutions, nursing departments within those institutions strive to receive magnet recognition. It's meant to, by having magnet recognition, it should make the institution, the nursing within that institution, more attractive to the public. It also makes it more appealing for staff nurses to work there. It's a formal recognition. People can, places can have a magnet situation without applying for the recognition program, which is sponsored by the American Association of Colleges of Nursing. And It, but it is a feather in one's cap to have magnet recognition. I'm aware that Altman in this area does. I know Mercy is pursuing. I know SUMA, or whatever it's called now, does, and I don't believe that General or Clinic. I'm assuming the Clinic does, but I don't know that all their facilities, meaning Akron General, Worcester Community, Barberton Citizens. I don't know that they. Not scratch that, but I don't know that they all have magnet status. And you have several readings on transformational leadership. And we've talked some about structural empowerment. And I'll let you review these fine pieces for your end. Sorry I've talked so long. But it was 50 slides long. So hope you found this helpful. Let me know if you have any comments or criticisms.